Dr. Jolissaint. And Joseph, if you want to go ahead and share your screen, and we will get rolling with Grand Rounds this morning.
Great. Thank you, Dr. Pat.
Perfect. We hear you loud and clear, and your screen is coming up, so take it away.
All righty. Good morning, everyone. My name is Joseph Jolissaint, and I'm one of the residents here at CMC. Today, I'll be discussing an innovative new treatment, Percutaneous Ultrasonic Tenotomy, and its role in the management of recalcitrant tendinopathies. I'd like to start with a couple cases to frame our discussion. Mr. B.A. is a 54-year-old active male mechanic who presented with lateral elbow pain throughout various daily activities. On physical examination, he demonstrated pain with resisted extension of the middle finger and exquisite pain to palpation over the lateral epicondyle. Here's his imaging showing calcifications at the common extensor origin. He was subsequently diagnosed with lateral epicondylitis and underwent extensive conservative management for 6 months, including physical therapy, bracing, activity modifications, and he had no substantial relief and some progressive worsening of his symptoms. Ms. GH is a 44-year-old active female physical therapist who presented with lateral elbow pain while working and during leisure activities such as rock climbing. On physical examination, she also demonstrated pain with resisted extension of the middle finger and exquisite pain to palpation over the lateral epicondyle. Her imaging similarly revealed calcifications at the common extensor origin. She too was diagnosed with lateral epicondylitis, underwent extensive conservative management, but also had persistent symptoms at 6 months. So chronic tendinopathy is a diagnosis which it's a major burden to the U.S. healthcare system and to the workforce, as this can be a diagnosis that causes people to be out of work. Over 30 million codes for chronic tendinopathy are charted each year in the U.S. Most are seen around the shoulder and elbow in the upper extremity and the foot and ankle in the lower extremity. I'd like to very briefly touch on the pathophysiology of chronic tendinopathy. The pathophysiology of chronic tendinopathy is rather complex and very well studied. While we're all familiar with this pathway in some shape or form, this is a continued area of research, and there have actually been over 15,000 publications on the pathophysiology, etiology, and treatment of tendinopathy since just 2017. Chronic refractory tendinopathy starts with some kind of an insult, such as an unaccustomed loading leading to micro tears, which then leads to a neurovascular mediation and a reparative signal. This neurovascular mediation and reparative signal results in a reactive tendinopathy, and in the vast majority of patients, this reactive tendinopathy or normal healing response leads to uneventful tendon repair. However, in some patients, this reparative signal appears to be lost or ineffective, leading to a chronic refractory tendinopathy characterized by disordered haphazard healing with an absence of inflammatory cells, scattered vascular ingrowth, and a poor healing response. And ultimately, it's these patients with the lost or ineffective reparative signal that go on to experience a chronic refractory tendinopathy. A study by Sanders et al. In AJSM in 2015 followed 5,867 elbows over a 10-year period. They found that 80% of patients had improvement of their symptoms by 6 months with routine conservative management, while 20% continued to have significant symptoms. Interestingly, they found that if you were one of these 20%, which continue to be symptomatic, that the average time to healing was greater than 2 years, meaning you were in it for the long haul. Additionally, they found that if your symptoms resolved prior to 6 months, that a full 15% or 1 out of every 6 had recurrence of their symptoms. So now that we have an idea of the burden of disease of tendinopathies, as well as the percentage that go on to have a recalcitrant tendinopathy, what are the current treatments? Well, there are non-invasive traditional treatments, which mainly consist of physical therapy, steroid injections, and bracing. There are more invasive procedural treatments such as dry needling, biologics, percutaneous ultrasonic tenotomy, which we'll talk about today, and arthroscopic and open surgical options. Regarding the procedural options, as many of you know, whenever there's numerous different options that physicians are utilizing for a certain condition, it's typically because none of them are really fantastic at treating it. So in the early stages of tendinopathy, physical therapy, specifically eccentric exercise, is the mainstay of treatment. This was first postulated in 1986 by Stanish et al. In Core, and since then it has been supported heavily in the literature. A systematic review published in the British Journal of Sports Medicine in 2007 further supported these findings. And there's actually some really interesting data to show that eccentric exercise may actually evoke or stimulate a healing response. An interesting paper by Nakamura et al. In 2008 took 60 rats given patellar tendon injuries and broke them into 3 groups: controls, eccentric exercise, and concentric exercise. They found that via angiopoietin 1 and decreased angiopoietin 2 in the presence of VEGF, eccentric exercise contributed to stabilized angiogenesis during the early phase of tendon injury, whereas concentric exercise induced destabilized angiogenesis. And that led to a delayed healing response. As many of you have seen in your practice, physical therapy is effective in many, but it's also variable in its effectiveness. For those in which it is effective, it's typically prolonged. Additionally, it is safe and can be cost-effective. However, the cost-effectiveness is based upon the duration of treatment and whether it's supervised or unsupervised. Another treatment, cortisone, has been extensively utilized in the so-called hot disease, keeping people from working, and this is still regarded as integral to the successful treatment of tendinopathies, despite the fact that their indications, effectiveness, and timing have been questioned. The biologic rationale for their use is also still debated. It's recognized that tendinopathies are very different and distinct entities from tendinitis and are a manifestation of overuse disorders and thought not to result from inflammation, but instead to be characterized by angiofibroblastic hyperplasia. Given that this is the case, using a potent anti-inflammatory agent in their management is somewhat counterintuitive. Coombs et al. Performed a randomized controlled trial comparing corticosteroid injection alone, placebo injection alone, corticosteroid injection plus physical therapy, and placebo injection plus physical therapy in lateral epicondylitis. And they found that corticosteroid injection resulted in worse clinical outcomes after 1 year compared with the placebo injection. Corticosteroid plus physical therapy did not result in any significant differences compared with the corticosteroid alone. And they did note that physical therapy alone, in the absence of any injection, provided short-term benefit in the lowest recurrence rates and highest recovery rates at 1 year, which we touched on. A systematic review performed by Hart et al. Evaluated several different tendinopathies in the role of corticosteroids, and he found that corticosteroid injections offered no benefit compared to no treatment at 1 year and only a slight improvement at 12 weeks. Additionally, he found similarly that physical therapy had statistically significant improvements at 1 year compared to steroid injections. So we know that 80% of patients resolve with conservative management and that 20 will go on to have chronic debilitating symptoms for greater than 24 months. But for those 20%, when should we intervene to try and change the natural history, and how should we do it? Well, Dr. Morey published some interesting data regarding the epidemiology and natural history of tendinopathy and AJSM in 2015. After evaluating 2,000 patients, he found that of the 80% of patients which recovered by 6 months, all reported significant improvements with an average improvement over 40% at the 3-month mark. The 20% of patients who went on to develop a recalcitrant tendinopathy had minimal to no improvement at the 3-month mark. Based on this, he recommends seeing patients at the 3-month mark. If they have made progress, then give them encouragement that their symptoms will continue to improve and eventually resolve. However, if they've made absolutely no improvement at the 3-month point with conservative management, and this is affecting their daily life or their work, he recommends at least beginning the discussion of definitive intervention. So, if we move on to definitive intervention, what's the ideal treatment for a patient that has failed conservative management? Well, in an ideal world, the treatment would obviously be better than any alternative. You would be able to identify patients who would otherwise be symptomatic for 2 years and treat them as soon as possible. It would fix the problem definitively. There would be a rapid recovery. It would cost absolutely nothing, and there would be no risks associated. Well, we also know there is no such thing as a free or risk-free treatment, and we know that ideal conditions don't always exist. So we must weigh the pros and the cons. Specifically in this scenario, for a condition that may likely resolve on its own in 2 years, we have to take into account the risk-benefit ratio as well as the cost-effectiveness ratio. So there are numerous interventional options for patients which fail conservative management and develop a recalcitrant tendinopathy. And these include dry needling, biologics, percutaneous ultrasonic tenotomy, as well as arthroscopic and open surgical procedures. Interestingly, dry needling has been shown to have some benefit for patients with chronic tendinopathy. Cray et al. Performed a meta-analysis in 2015 evaluating various tendinopathies and noted modest improvement in patient-reported outcomes. This treatment appears to irritate the location of the patient's symptoms without removing any disease tissue and potentially stimulates a healing response. And these findings are interesting as they may indicate that any formal mechanical intervention which irritates tissue may be effective. There's been a surge of interest in biologics over recent years for the treatment of chronic tendinopathy. Lin et al. Published a meta-analysis in arthroscopy in 2018 comparing autologous blood-derived products, including PRP, versus placebo in patients with Achilles tendinopathy. And they found that these were not more effective than placebo in Achilles tendinopathy, and that there was no association between therapeutic effects and duration of benefit. Little et al. Published a systematic review of PRP and patellar tendinopathy, and of the 11 studies included, only 2 of them were randomized controlled trials, and they concluded that PRP is safe and promising in the treatment of recalcitrant patellar tendinopathy. However, its superiority over other treatments such as physical therapy remains unproven, and more randomized controlled trials are warranted. Fitzpatrick et al. Published a meta-analysis of randomized controlled trials evaluating the effectiveness of PRP in the treatment of various tendinopathies. And using a standardized mean difference cutoff of 26, they found inadequate benefit from saline, local anesthetic, corticosteroid, and dry needling, and a positive benefit with leukocyte-rich PRP and leukocyte-poor PRP, as well as autologous conditioned plasma. Additionally, PRP is still an out-of-pocket expense for patients. And as we've discussed, the literature varies clearly. However, some patients are so symptomatic and they want to avoid surgery so much that they are willing to pay out of pocket for these treatments. Surgical treatment for chronic tendinopathies are typically reserved for truly refractory cases that have failed non-operative management, and the goal of surgery is to remove diseased tissues. While there is literature that suggests surgery's benefit in patients that have failed non-operative management, the results are variable. A double-blind placebo-controlled study by Crosslick et al. And AJSM failed to show any additional benefit of surgical excision of the degenerative portion of the ECRB over placebo for the management of chronic tennis elbow. A randomized controlled trial by Bear et al. And JBJS showed that no advantage was demonstrated for surgical treatment compared with eccentric strength training in patellar tendonitis, and recommended that eccentric training should be tried for 12 weeks before open tenotomy is considered. Hunt et al. For the foot and ankle literature showed improvements in AOFAS and VAS scores for two different surgical techniques in patients that failed non-operative management for chronic insertional tendinopathy. However, Pavola et al. And AJSM in 2000 reported a 10% complication rate in patients undergoing surgical treatment of Achilles tendinopathy. So while surgery has been shown to improve symptoms in some patients with chronic tendinopathy, it isn't clear to what degree, for what conditions, and there are real risks with surgery that should be weighed against benefits. In fact, in a Cochrane review regarding lateral epicondylitis, Buchbinder et al. States that there is not enough information to tell if surgery would make a difference in the quality of life compared to not having surgery or to non-operative treatment. So given the risks associated with open surgical treatment and the need for recovery, there have been efforts to discover modalities which are able to remove diseased tissue in a similar fashion as surgery while offering a minimally invasive approach and little to no recovery. These efforts led orthopedists, sports medicine physicians, and interventional radiologists to develop and adapt ultrasound technology. This technology was actually predicated and adapted from the field of ophthalmology. The ultrasonic probe used in ultrasonic percutaneous tenotomy was developed for phacoemulsification. Phacoemulsification is a modern cataract surgery method in which the eye's internal lens is emulsified with an ultrasonic handpiece and aspirated from the eye, while the aspirated fluids and debris are replaced with a balanced salt solution to maintain the anterior chamber. And this procedure absolutely revolutionized the treatment paradigm for cataract surgery. It allowed it to be performed as an outpatient procedure under local anesthesia, and this has safely and effectively been performed for over 30 years now. The ultrasonic probe consists of two parts, a hollow probe and a sheath. The hollow probe is an 18-gauge needle which transmits ultrasonic energy. And as the ultrasonic energy breaks up the diseased tissue, it is simultaneously extracted via suction on the probe. The probe is also covered by a sheath which emits irrigation and ensures appropriate temperature regulation, preventing damaging of normal tissue. These are similarities to open surgery in the fact that it cuts and removes diseased tissue, but it's able to do so in a percutaneous fashion. The energy which is transmitted to the probe is done so via a console, which can be seen here. And as I mentioned, this ultrasonic energy is able to cut diseased tissue while not affecting healthy tissue. So a study done at the Mayo Clinic looked at the effect this ultrasonic energy has on collagen bundles in an animal model. They took both normal collagen bundles as well as collagen bundles damaged via a collagenase and exposed them to this ultrasonic energy. The first picture in the top left is a histological slide of a normal tendon with organized, tightly packed fibers. The picture in the top right is the same tendon after exposure to continuous energy in a discrete point of application. As can be seen, there is little change in collagen morphology, and there are no ruptured or fractured bundles. The picture on the bottom is a tendon experimentally degenerated with collagenase, and this void in the middle reveals a tract of removed tissue after treatment with the percutaneous ultrasonic tenotomy device. In a study published in the Journal of Orthopedic Surgeon Research, Kaminami et al. Evaluated the effect of percutaneous ultrasonic tenotomy on the collagen profiles as well as the histological appearance of a rabbit Achilles tendinopathy model. They found that treatment with percutaneous ultrasonic tenotomy resulted in a qualitative and quantitative collagen profile and improved histological appearance similar to that of healthy Achilles tendons by 3 weeks. This is important in that it indicates that while the percutaneous ultrasonic device does indeed remove diseased tissue, it also may stimulate a healing response. In addition to the normalized and collagen profile identified by Western blot seen on the last slide, similar results can be seen histologically. A is a normal Achilles tendon. B is a necrosis and disorganization of an Achilles tendon induced by a collagenase at 6 weeks. And C is that same the same slide, and this is the Achilles tendon after 3 weeks of collagenase and 3 weeks of treatment with the percutaneous ultrasonic device. And as evident, this reveals a repopulation of the evacuated cavity and early collagen bundles. Okay, so there's basic science evidence in an animal model that percutaneous ultrasonic tenotomy may generate a healing response and normalize collagen profiles, but what are the results in humans? Coe et al. Were the first to publish results of a series of patients using the percutaneous ultrasonic device in AJSM in 2013. Their study was titled Fasciotomy and Surgical Tenotomy for Recalcitrant Lateral Elbow Tendinopathy, Early Clinical Experience with a Novel Device for Minimally Invasive Percutaneous Microresection. They looked at the results of 20 consecutive patients who failed non-operative intervention for an average of 12 and a half months and subsequently underwent percutaneous ultrasonic tenotomy. They evaluated numerous patient-reported outcomes and ultrasound measurements and found improvements in VAS, DASH compulsory, and DASH work scores at 3, 6, and 12 months. Additionally, they found sonographically reduced tendon thickness in 19 patients, resolved or reduced hypervascularity in 17 patients, and reduced hypoechoic area in 18 patients. 19 of the 20 patients, or 95%, expressed satisfaction with the procedure. Sang et al. Followed up on these patients at 36 months and published their results in AJSM in 2016. They had 100% clinical follow-up, and this was inclusive of ultrasonographic assessment. None of the subjects required further treatment procedures, and 100% expressed satisfaction. Previous improvements in visual analog scale and DASH work scores were sustained with conformity to a linear pattern. There was further reduction in DASH compulsory scores to a median of 0, and with a significant decrease on repeated measures. As can be seen on the bottom left, tendon hypervascularity was resolved in 94% of patients, and 100% had a reduction in tendon thickness. As can be seen on the bottom right, overall reduction in the hypoechoic scar tissue was observed in all subjects, with a 90% response rate achieved by 6 months. And between 6 and 36 months, further reduction in the scar was observed in around 60% of patients, with 20% having complete resolution. So what are results in other areas? Well, Ellis et al. Published their 16-month results of 26 procedures in 25 patients who underwent Achilles fasciotomy and surgical tenotomy for incisional Achilles tendinopathy. They used the foot function index to quantify pain, disability, activity limitation, and overall scores, and noted an 85% success rate. Chimenti et al. Additionally evaluated 40 instances of percutaneous ultrasonic tenotomy for recalcitrant Achilles tendinopathy and noted improvements in AOFAS and SF12 scores. They additionally noted 1 superficial infection, which resolved with oral antibiotics. Rasdan et al. Evaluated 100 patients who were treated with percutaneous ultrasonic tenotomy for recalcitrant plantar fasciitis and noted improvements in foot and ankle disability index scores at 3 and 6 months and an overall satisfaction of 90%. Patel et al. Prospectively evaluated 12 patients with chronic plantar fasciitis in which patients were either allowed to undergo non-invasive treatment or to undergo focal aspiration and partial fasciotomy with an ultrasonic probe. They noted that all 12 patients were pain-free with a mean VAS less than 1 and reported that the procedure appears to be safe, effective, well-tolerated, and that for those patients where it's refractory to other options. Baker et al. Additionally prospectively evaluated 29 patients with gluteal tendinopathy who did not respond to non-surgical treatment. They underwent ultrasound-guided percutaneous ultrasonic tenotomy and published their results in AJSM in 2020. Outcomes were assessed with a visual analog score for pain, the Harris-Hip score evaluation, and the SF12, and they noted improvements in each of these measures. They reported no complications, and they concluded that percutaneous ultrasonic tenotomy is a valid, safe, and effective option. As we discussed earlier, while the prior studies evaluated the benefits, we also must take into consideration the risks associated with the procedure. Dr. Mori published the complications of approximately 70,000 procedures and noted 13 complications: 3 tendon ruptures, 1 permanent nerve injury, 2 infections, 6 probe breakages requiring retrieval, and 1 skin burn. And now that we have an idea of risks and benefits of percutaneous ultrasonic tenotomy, let's return to our cases. So BA, the 54-year-old male mechanic who failed non-operative management, he subsequently underwent percutaneous ultrasonic tenotomy. His pain was better at 1 month, and he was symptom-free completely at 2 months. GH, our 44-year-old female physical therapist, failed non-operative management, and she continued to undergo conservative management. She had symptoms for an additional 3 months. However, at the 1-year follow-up, she was symptom-free. So in summary, tendinopathy is a significant burden. Most improve with rest, NSAIDs, splinting, activity modification, physical therapy, and time. However, 15 to 20% become recalcitrant, and those are the hard ones to treat. And of the 15 to 20% that become recalcitrant, there are numerous treatments because none are fantastic. However, percutaneous ultrasonic tenotomy is an option. There are promising results. It's minimally invasive with results similar to other more invasive treatments. It removes diseased tissue. There are low complications. However, higher quality studies are needed. I'd like to give a big thank you to Dr. Morey, who was instrumental in getting this talk together, as well as a big thank you to Dr. Connor, Dr. Cohen, and Dr. Hammond. As always, big thank you to my class for all their support, as well as my wife and kids for their support. And we'll move on to any questions.
Thanks, Joseph. That's excellent. It's definitely sort of a great grand rounds topic, something that's sort of a little bit on the cutting edge / expanding into clinical practice. So if you were being interviewed by the newspaper to tell them about this, this new treatment, what would you list as the top 3 indications for it?
Yeah, I think the top 3 indications for me would be someone that is truly recalcitrant. Dr. Morey talked about how he starts the discussion at 3 months. And, I think you can start the discussion at 3 months, but I think it should really be someone that's, exhausted all non-operative management, out to 6 months or 1 year. So if they've exhausted, number 1 would be exhausted everything else. Number 2 would be if this is affecting their work, right? We see a lot of patients that are out of work.
I'm gonna pause you, Joseph. I like where you're going with this, but you're in the newspaper. We got to be brief here. Top 3 indications. Right. I want diagnoses. What are we going to use it for?
Oh, you mean like diagnoses?
Yes.
Refractory lateral epicondylitis, failed conservative management, out of work for a year is number 1. I think the best evidence is in, lateral epicondylitis. Okay. I think, gluteal tendinopathy in a patient that has failed all conservative management and is averse to an open surgical treatment. I think gluteal tendinopathy is an area that's hard to treat. So I think there's some emerging research for that. And then I would say, for the patient that has recalcitrant plantar fasciitis, that doesn't want to go an open surgical option, or is maybe a patient with wound healing issues, diabetes, things like that, as it may be a less invasive approach to remove diseased tissue.
Great. Could you stop sharing your screen so we can see everybody's faces? And question to some of the faculty on who use this. How have you adapted this technology / procedure into your practices? Is it something that is creeping in, or is it something that is really taken over as a major utilization for you all?
I guess this is Dr. Cohen. I'll start. It is creeping in. I use it as a solution for a problem that we don't have a great answer for. And that is a patient with recalcitrant plantar fasciitis. Most will have symptoms for over a year. They failed physical therapy. They failed corticosteroid injections. And it's an alternative to an open procedure that I think it has equivalent results. While those results aren't great, I think the downside is so much less than a large open, than an open plantar fasciotomy that has a longer recovery. So that I usually offer the patient both. So it's usually when we're at the end of the road. So I probably do this a handful of times per year.
So this is really as in your algorithm, it's sort of when you hit that fork to talk about surgery, you talk about this as the other arm in that algorithm.
Yeah, absolutely. So my utilization of this over the last 3 years hasn't increased at all. So this is real. So I'm pretty judicious with recommending surgery for these patients, but when I do, I offer them this minimally invasive approach.
about any of the elbow folks or hip folks?
It's Natty Hammett. I actually have not incorporated this into my practice. I don't know if Pat's on there, but there are several people that have used it a good bit in Charlotte. But Joseph, could you just tell us quickly how logistically this procedure is performed for the audience? Is it done in the office, in the operating room? How is it covered completely by insurance? Is it out of pocket?
Yeah, absolutely. So I'll start by saying this procedure can be done anywhere. In Singapore, especially, or other countries, it's done, in the office on an examining table with an ultrasound probe to kind of just guide where you're going. However, in the United States, it's a little different, and that's because in terms of reimbursement, it is covered by insurance. However, because of reimbursement, it's typically done in an ambulatory surgery center. And it's not because it needs to be done there, but that's just because of reimbursement factors.
Yeah, hey, this is Dave Price. Just we have not. I'm a primary care sports medicine doc, and I think in theory this is a great thing for us. It's because it's always required that surgical suite, like you're saying. It's not been as adapted into a lot of practices. So we've kind of gone more the biologics route. I have seen good efficacy, and I know some of my partners have said, I think T had his primary care sports guy at Duke who had the ability to go to a surgical suite. Said, if it's covered by insurance, I'll do that. If it's not going to be covered by insurance, I'll do PRP. And I thought that was a good way of doing it. The hardest thing I've found, and I'm curious on your thoughts, is I see a lot of mechanics or folks who have to get back to work. And that's probably the biggest. So they don't want something where they're going to have this downtime for a month, right? So that's number one. So those are the guys that say, I don't care if a corticosteroid injection isn't going to help me by 12 weeks. I can't take this anymore. I need to get back by tomorrow, right? And so those are the guys that it's hard not to convince, that they say, just keep giving me this until I rupture the tendon, then I'll get surgery, then I'll deal with it. So, that case you said of the mechanic, I think that's good if they can get their company to support them for the time off. I think it's not really happened much in my practice. And the second thing with these high deductible plans, it throws 10x out the window a lot of those times. And people will say, I'd rather just try the PRP for the, $500. So just some of my experiences, but I appreciate you bringing it up. Good talk.
Joseph,
Connor,
great. This is a good talk, and really appreciate you bringing it up. It's an important technology and an important topic, but these tendinopathies are really all different. When you're talking about lateral epicondylitis versus patellar tendonitis versus a rotator cuff tendinopathy versus an Achilles tendinopathy, they're really all different. Different treatments work better. I didn't see Glenn Gaston on the call. I was waiting for his comment, but I actually borrowed a talk from him that I used in a biologics meeting at AOSSM last year on the success of PRP for lateral epicondylitis. And as you know, or you may not know, I don't know. I don't know what folks know about this, but the leukocyte-rich PRP has been shown to be very effective for lateral epicondylitis. It beats corticosteroids every single time and surgery most of the time. So I'd love to see a trial of the 10X and the leukocyte-rich PRP side by side for elbow tendinopathy. It's not the same with the others though. Patellar tendonitis has been more refractory. 10X I think is better for that than the PRP. So it really, you almost have to know your indication. So I think Josh's newspaper question to you was really good, because with every technology, you need to know the indications. That's what Bruce was intimating early.
I would agree. It's Pat Connor here. I would agree too with your comments. Not only are all the different tendinopathies different, but lateral epicondylitis is not necessarily lateral epicondylitis. There are some, we've done some we're doing some ongoing research and getting MRIs, and sometimes they're partial thickness tears, sometimes complete tears that I think that should be treated differently. But great talk. I think there is a lot of promise with this. It definitely works. We just need to find the right niche for it. Big kudos to Joseph for a great talk. There's not many that would just pick up the phone and call the the world leader in a certain technology and talk to him about some pearls. So Joseph, great initiative and a great talk.
All right, we're at the half